I'm going to be talking about our recently published paper on osteoporotic fractures. And basically, we formed an international working group. It was multidisciplinary with radiologists, nuclear medicine, and clinicians. And we were representing multiple societies dedicated to achieving excellence in skeletal health assessment and management. My name is Aliya Khan. I'm a clinical professor of medicine at McMaster University and the director of the Calcium Disorders Clinic and the director of the fellowship in metabolic bone disease at McMaster University. I'm the co-chair of the International Working Group on Dexa Best Practices. And we have just completed our first paper on osteoporotic fractures, diagnosis, evaluation, and significance. And this paper will be published in the July edition of Mayo Clinic Proceedings. We identified key areas that need to be emphasized. Number one, we want to emphasize that osteoporotic fractures need to be taken seriously because they are associated with significant morbidity and mortality. And currently there is a care gap of approximately 70%, and this is very significant. And what we are advocating is that we identify fractures and then determine if this was a low trauma fracture or a fracture which occurred with significant trauma. We recognize today that even fractures that have occurred with significant trauma are associated with bone density. So if someone has low bone density, they're more likely to have fractures in a car accident, for example. If someone has a low trauma fracture, this confirms that that individual has impaired bone strength. And this could be because of decreases in quantity or decreases in the quality of the bone. And it is important for us to exclude an underlying pathologic fracture with appropriate imaging and also secondary causes of osteoporosis. And in this paper, we identify the key investigations which need to be completed to ensure that a secondary cause for that fracture is excluded, and also for the underlying osteoporosis that led to the fragility fracture which took place. We want to identify fracture risk based on the patient's age and multiple risk factors of fracture, which also include family history of having had a fragility fracture, smoking and alcohol use, as well as diseases that are associated with osteoporosis. And we recommend that individuals be evaluated looking for diseases associated with osteoporosis, as well as drugs associated with osteoporosis, such as steroids, aromatase inhibitors, androgen deprivation therapy. And in the paper, we identify the key areas that need to be reviewed in the clinical assessment. It is important to remember that 2/3 of vertebral fractures are silent. And in an individual who has had height loss, 2 centimeters of height loss observed, or historically 4 centimeters of height loss, these individuals do need to have further evaluation with spinal imaging. As well, if someone is having back pain or has developed kyphosis, clearly we're going to be doing additional spinal imaging. And what we're looking for are vertebral deformities or vertebral fractures. We can do spinal imaging, and a way to identify the presence of a vertebral fracture with minimal radiation exposure and at low cost is vertebral fracture assessment. And at the time that our patient has a bone density assessment done with Dexa technology, we can do a vertebral fracture assessment and get a good image of the entire spine. And this can be very helpful in confirming the presence of a vertebral fracture, and this can be helpful in identifying fracture risk. It is important to remember that we have major osteoporotic fractures, minor osteoporotic fractures, but major osteoporotic fractures are fractures that occur at the hip, spine, forearm, and humeral sites. Minor osteoporotic fracture sites are all other fracture sites with the exception of face, skull, hands, feet, and ankles. And if we have a good assessment of the number of fractures that our patient has had, we can plug all of this information in to the FRAX assessment and then evaluate their fracture risk and go ahead and start effective therapy. We also emphasize the importance of using other tools to assess the quality of bone. And we recognize that Dexa has limitations. One of the limitations of Dexa technology is that it overestimates the BMD in tall individuals, and it underestimates bone density in petite individuals. We also recognize that degenerative changes and vascular calcification can result in a falsely elevated bone density at the spine. So we do recognize that there are limitations to DEXA technology, and a patient may have impairment in bone quality that can be seen with certain diseases, such as chronic kidney disease, poorly controlled diabetes for several years, parathyroid disease. And in these individuals, using a trabecular bone score, and this is a tool that is applied to the lumbar spine assessment, the DEXA image, and it enables us to determine bone quality. And this has very good correlation with HRPQCT imaging. So we are recommending that we evaluate our patients and supplement DEXA technology with vertebral fracture assessment and TBS, ensure that we complete a comprehensive assessment, exclude pathologic fractures, and exclude secondary causes of osteoporosis, and evaluate fracture risk and initiate therapy. So I welcome you all to review this paper. It has been endorsed by several international societies dedicated to skeletal imaging and skeletal assessment and skeletal health. Thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.